Well, hi everyone. My name is Alex Cheetham. I am a EMS fellow at the University of Cincinnati and a pediatric emergency medicine attending at Cincinnati Children's. And today we are going to be discussing the pre-hospital evaluation and management of geriatric patients. So the objectives for this talk, we're going to be discussing the epidemiology of this patient population, how to assess an elderly patient, the physiology of aging, and then specific medical conditions in the elderly, and we'll go through that basically organ system by organ system, how the body changes over time, and then what medical conditions may be related to that. Then we'll discuss geriatric trauma very briefly, and then finally we will touch on elder abuse. So first we're going to jump into talking about the epidemiology of this patient population, and this basically goes to why is it important for us to understand how to evaluate, assess, and manage patients who are elderly. For context, that patient population that we're talking about is any patient over the age of 65. And this graph basically shows you that for this patient population, the number of patients who are over the age of 65 has been increasing over time. So in the 2020 census, 1 in 6 people in the United States were over the age of 65. It's also a population that's growing at its fastest rate since decades and decades ago. And mainly this is because these are our baby boomer generation, so all of the people that were born in the 50s, 60s are now coming to be a part of this patient population. This graph just describes to you in a slightly different way how the population is changing. Basically, not only is the elderly population growing, but the people that make up that population are also getting older. So the graph on the left here is the 1960s. It has sort of a pyramid shape where really the most people that we had in the population were younger people or middle-aged people. Now we have more of this kind of column-shaped population that you can see here as sort of like projected in 2060, but we're really on our way there, where our older patients are becoming older. So for patients ages 65 to 74, this population is 8 times larger now than it was in 1900. For the 75 to 84-year-old age group, the patient population is 13 times larger than it was in 1900. And for patients over the age of 85, that age group is 24 times larger than it was in 1900. So the demographics of this patient population are changing, and there's more of them. Finally, this is just sort of a neat infographic to show the projected trends of the age of patients over time and the general population. And we sort of are nearing this tipping point around 2034 here, where the number of adults age 65 is going to outnumber the number of children. And this has never happened in the history of the United States, and so it's going to be an interesting change and an interesting sort of evolution for our population. Now, where are these patients? I think it's important to recognize that Ohio, which is where we are right now, is here on the list of patients regions of the country where the most patients over 65 plus live. And so you can see in the map on the left, basically the darker shaded states have a higher percentage of people over the age of 65. And then this list on the right just demonstrates to you that over half of patients, or over half of people, over the age of 65 live in these states. And impressively, like I said, Ohio made it to the list. So what's some other stuff about this patient population? So we've talked about the fact that there are more elderly individuals living now, that those people and patients are older than they used to be. But what sort of impacts this patient population? So it's important to understand that many of our elderly patients are actually going to be living below the poverty line. So more than 17 million, or 1 in 3 older adults over the age of 65 are economically insecure with income below 200% of the federal poverty level. For those patients and individuals who are on Social Security income, they receive on average just over $500 a month from Social Security. And there's major disparities in how much people earn on Social Security. Specifically, older women and women of color fare worse than their counterparts of a similar age. Just to give you an idea of how much that just over $500 in Social Security income gets you, this is an example of kind of an online calculator that gives us a sense of how much it's going to cost to live in an area. So I picked Hamilton County, Ohio, which is where we are right now, for an individual who is sort of like decent but not perfect health, and their monthly expenditures are anticipated to be over $2,000 a month. So if you're living below the poverty level, if you're only making $511 a month on Social Security, and your expenses are over $2,000, you can see why these patients and individuals may have some struggles that the rest of us may not be as kind of attuned to. And what are the healthcare implications of getting older, right? So basically, as people are living longer and our patients are getting older, there's a higher incidence of many chronic diseases. So the common ones are listed up here, but high blood pressure, high cholesterol, arthritis, heart disease, diabetes, chronic kidney disease, heart failure, depression, Alzheimer's, and COPD. These are all chronic and potentially complex medical conditions that are becoming more and more common as we have an older population. So not only are patients maybe struggling in terms of finances or income, not only are they also caring for more chronic illnesses, but there are implications about the living arrangements for elderly individuals in the United States. So these two graphs kind of show us where and how these individuals are living. So most people still are living at home or living with a partner or spouse. More women than men live in nursing homes. And as you get older, it's more likely that you're going to live in a nursing home. So 1% of people ages 65 to 74 live in a nursing facility, 2% if you're 75 to 84, and that jumps up to 8% for people over the age of 85. There's a lot of social issues to consider when you're thinking about your geriatric or elderly patients. Some of the social situations may be sort of more limited or difficult for those patients, and the living situation, so living in a care facility, living in a communal facility, may actually foster an environment where certain illnesses can occur more frequently. We've already discussed financial difficulties. There are physical difficulties simply as a normal part of aging, but they may be exacerbated by some of the medical conditions that people face. And then there may be emotional issues, right? So solitude or lack of personal contact, loss of family or friends. Many of us are maybe familiar with these concepts for people in our own lives, but we need to think about and respect and understand these things when we're interacting with elderly patients. And then finally, and unfortunately, and as we'll discuss right at the end of this presentation, our elderly patients can be the targets of abuse. And finally, we'll talk about a lot of different ways in which medications can be problematic in these patients, but having a low income may actually impact their health status in a variety of different ways, from being able to maintain medications or comply with medication regimens, poor nutrition or issues with living situations, poor housing situations, those types of things, and all of these can exacerbate underlying medical conditions. When we're thinking about our interactions with elderly patients, many of us are coming from generations that are far removed from them, from experiences and lived experiences that are very different from theirs. And it's really important to go in with an open mind, with being respectful and trying to understand a little bit of where these patients are maybe coming from. There may be a hesitancy for patients to seek help. They don't want to be seen as helpless, may not want to impose on others. They may fear that by asking for help, that might mean that down the road or very soon, it's going to lead to a loss of independence. Or there may be fear in the fact that this decline is inevitable, or a change is inevitable, and that's scary, right? So we need to think about that and, again, be respectful of it. And when you're providing care, there's several things to consider, and these will come up again and again throughout this presentation. But decreased level of functioning might actually indicate some sort of untreated illness. Your geriatric patients may be anxious. They may be aware, again, of their own morbidity or mortality. And you may encounter situations where it's difficult to kind of sort out the decision maker or potentially have access to the appropriate documents and those sorts of things as people reach the end of life and may or may not have set in place decisions or proxies to make those decisions ahead of time. What are some of the myths about aging that we can just kind of dispel right away? We've talked about several things that might be common to the elderly patient population or geriatric patients, but it is very, very important not to kind of blanket apply those issues across the board, right? We're treating individuals. Individuals all have their own situations, and so it's important not to take those kind of concepts and just say, okay, this applies to everyone, right? So some myths that might be out there that you may have heard. Most people are senile or demented. Certainly, there are members of the elderly community that have this issue, but you can't go into every experience and every interaction assuming that of someone. That most elderly persons feel miserable most of the time. Yes, there's social isolation. Yes, there's depression. Yes, there are emotional issues. But again, don't make that assumption of everyone. That elderly people maybe cannot work effectively as younger individuals, that they are all unhealthy and might need help with kind of normal, typical tasks, or that they're all socially isolated or lonely, right? So again, concept that we mentioned and touched on as being concerns or maybe applicable to a large number of elderly patients, but not everyone, and you don't want to make those assumptions. All right. So we've covered kind of who this patient population is, some of the unique challenges facing this patient population, and a little bit about kind of how you might start to think about your interactions with them, how your experiences and theirs may be different, and really, again, to go in with a whole boatload of respect when you're interacting with an elderly patient. So now we're going to move into really how to assess an elderly patient. All right. I've said it, I'll say it again, and I'll say it again later in this presentation, but we're going to talk about communication. So first and foremost, be respectful. You should talk to the patient first rather than talking to the caregiver. By talking to a caregiver before you talk to the patient, that immediately demonstrates to the patient that you've made an assumption that they cannot communicate with you effectively, right? So talk to your patient first. If then you realize that they, do have Alzheimer's, that they cannot communicate with you, that there is some issue, well, great, you have a caregiver as a backup. But talk to your patient first. Be understanding, again, that their lives may have been very different from yours. Actively avoid ageism, right? We all come into every single interaction every day of our lives with some degree of bias. This is a situation where you need to be proactive and recognize that we all probably have some degree of ageism, and you need to do your best to absolutely avoid that. Be really clear in the way that you communicate, right? So enunciate, speak clearly, and explain what you're doing before you do it, right? We don't want to just dive right in and start assessing someone. We want to give them a heads up and let them know what we're doing. And remember that it is going to take some time and some patience for the most part when you're interacting with elderly patients. Some of the challenges that you may face interacting with an elderly patient in terms of your communication with them, there may be issues with hearing or vision. There may be altered or confused. There may have complicated histories, right? This might be a meandering story. You might not get to the true heart of things right away. Or there may be effects of their medication kind of impacting their ability to communicate with you. So some kind of tips for you guys: face the patient, reduce background noise. If you can, have the light coming from behind the patient so that it actually is lighting you so that you are kind of more obviously lit for the patient. That can be helpful. Stay near the middle of their vision, right? So oftentimes a patient's sitting on a chair and we come and stand on the side of them and try and interact with them that way. Well, now you're in the periphery. They may not be able to see you as well. So get in the center of their vision so that you're nice and clear. Speak slowly and just enunciate your words clearly. So in that last slide I mentioned, it may be difficult to get kind of a precise story from an elderly patient for a variety of different reasons. Some of that is actually that they're going to present atypically for a lot of different medical conditions, like we'll talk about later. But it is important for you to get to the bottom of, really what is their acute complaint, what was the mechanism of injury, what is their main concern, And this can be challenging. It might be challenging because of altered mental status or dementia. It may be challenging because their complaints may be vague and may not even relate to the organ system that is the main problem. Patients may minimize the severity of their symptoms, again, because they don't want the implications of, what it means to be taken away and go to hospital. They may not want to be seen as being helpless, all those things we already talked about. There might be multiple things going on, right? As we get older, all of those medical conditions that we talked about get more common, and there might be more than one kind of piece of the puzzle there. I already mentioned that their chief complaint may not actually be the main problem, so it might be a different organ system that is impacting another one. Sort of UTI causing confusion is probably one of the easiest and most common examples. And it may be difficult to tease apart what is a new and acute problem as opposed to their maybe more chronic complaints. And then polypharmacy is a huge, huge challenge for our elderly patients, and it can really complicate the presentation, not only of their symptoms, but vital signs and everything else. So why are meds such a challenge? They might change how a patient responds or reacts to an illness. Even commonly used medications can have dangerous side effects for elderly patients simply as a function of how they act on an aging body, but also because of the medication's side effects and interactions that it may have with other meds that they're on. And some of the most common medications that are really important to pay attention to and can have really dangerous side effects for the elderly are things like antihistamines, antidepressants, benzodiazepines, barbiturates, alpha blockers, and NSAIDs. So some pretty common stuff up here, unfortunately, but these are important things to pay attention to. And sometimes there's a really long med list, but we need to kind of go digging a little bit. Some other sort of specific examples of medications to be wary of, or at least pay attention to. Antihypertensives, right? These may make your patients orthostatic. It may mean that they can't vasoconstrict in response to that normal response to standing up and getting up and moving, and may cause hypotension. So although a patient is normally hypertensive, now they're sick and they're a little bit lower than they should be, and they're still taking their antihypertensive, so that's going to bump them down even lower and give them symptoms. Beta blockers can cause issues in COPD, also makes it difficult for you to maybe assess heart rates in patients. Aspirin and NSAIDs, we all know, are huge common culprits for GI bleeds. Anticoagulants, again, huge issues with GI bleeds and can have major bleeding in patients on blood thinners or anticoagulants, even with mild trauma. And then antidepressants can cause a whole host of side effects that may impact your patient's presentation. So our elderly patients are going to have polypharmacy. They're going to have drug-drug interactions. Many of those drug interactions even actually result in hospitalization. They may not be able to comply with these complex medication lists as a result of memory loss, financial issues, physical constraints, or the fact that it's just so complicated, right? We've all had that little old lady who has, an entire Ziploc bag full of meds, and she doesn't really know what's supposed to be done and what's supposed to be taken or given when. They may be more sensitive to the drugs, or some other aspect of their normal, typical aging process may mean that they can't clear the medication as well, so things like decreasing renal function with age. When you're assessing an elderly patient, this is just kind of scaffold or template for you to think about if you like mnemonics. Personally, I'm not great with them, but for some people, they're really helpful. So this is the GEMS diamond. So the G is for geriatric patients. So we're trying to figure out what is normal aging as opposed to what is a new problem, and understanding that these patients are going to present atypically with illness for many of the reasons we discussed. Environmental, assessing the safety of their environment, paying attention to neglect or abuse. M, medical assessment, so paying close attention to their past medical history, any medications that they're on. And then S is the social assessment. When we're assessing elderly patients, again, a theme that's going to kind of come through, hopefully, in this presentation is that it is difficult to sometimes tease apart what is new, what is old, and there may be more than one thing going on. So 85% of patients over the age of 65 have at least one chronic illness. A third of them almost have more than 3 chronic illnesses or 3 or more chronic illnesses. One system issue may put stress on another system. So again, that plays into the fact that the chief complaint or their immediate concern may not actually be the problem organ system, right? It may be something else. Similarly, symptoms of one process may mask symptoms of another process, or treatment of one may mask symptoms of the other. So it can get kind of challenging to tease all of this apart. And they're going to present atypically with common illnesses. And again, we'll go through specific examples in all the different organ systems here during this presentation. But there may be effects of medications on vital signs. Their pain perception may be diminished or absent. Their temperature regulation may be depressed. So a septic elderly patient may not spike a fever. And then they may have depressed thirst mechanisms. So that's going to impact their ability to kind of compensate for maybe mild dehydration or something else where an intact thirst mechanism would actually be helpful. It's difficult in these patients, again, to tease apart what's normal aging versus what's new, and hopefully this presentation will help guide you and give you some tools with which to do that. But we have to be really careful about either attributing genuine symptoms to normal aging rather than a disease, or attributing parts of normal aging to being part of a disease process. So it goes both ways, and unfortunately it is tricky. If a patient has sudden or rapid altered mental status, for example, that does not fit with dementia, right? So we can't just put that new rapid change in a bucket of chronic ongoing issue for that patient. So we can't assume that a confused patient is just going through their normal kind of progression of dementia or is just senile. Abdominal pain, really tricky in elderly patients, and we need to realize that they may not present typically with kind of the standard severe belly pain in the case of an intestinal obstruction or things like that, because their pain perception is different. They present with MIs very differently, and falling may not be always mechanical, right? It's not always that they slipped and tripped or were climbing up a ladder. It may have been that they fainted as a result of a seizure or an MI or an acute arrhythmia, those sorts of things. So there's often a medical component to falls, and it's important for us to tease that apart because you guys are the ones on scene with that immediate information and kind of seeing kind of how things are laid out and what really went down. And don't assume that when they're dizzy that that's normal. All right, some more challenges. Again, I promise that we'll go through really what to look for and how to tease apart normal aging from disease processes. But I do want you guys to recognize that there's certain parts of both the history and the exam that are more challenging, and that's why we need to talk through them. So some of the physical exam findings in an elderly patient might be misleading. Their skin may mimic decreased skin turgor. So one way to kind of combat that is to assess skin turgor over the cheeks. They may normally be mouth breathers, but that may mimic dehydration because their mouth is so dry and tacky. For patients who are inactive, they may have edema simply from being inactive rather than from maybe a CHF exacerbation or something like that. They can have normal mild crackles at the lung bases, so that may again not be a sign of illness. And sometimes their peripheral pulses may be difficult to feel. That may be because of meds that they're on or deconditioning, those sorts of things. But that may not be pathologic. So teasing these things apart and understanding how your exam and your history go together become critically important for our elderly patients. Your mental status exam is incredibly important. Try and examine the patient somewhere that's warm, right? The moment you put them in a cold area, that's going to impact your ability to get a good exam. Remember that these patients may fatigue easily, so you don't want to walk them all the way to the rig. You're going to need to help these patients out a little bit more. They may be uncomfortable in certain positions, right? A patient with kyphosis is going to be really uncomfortable with their kind of back being hunched, laying flat down on a bed or particularly on a board. So try to examine patients in a position that is comfortable for them. Be respectful. Again, a lot of this comes back to that, but protect their modesty. If you're getting an EKG on an elderly patient, right, just be careful and thoughtful about how you place their clothing or keep them covered up. And they may have decreased pain sensation, and so be sensitive to that throughout your exam in terms of kind of how hard you may be manipulating or assessing different aspects of the exam. Simple stuff remains simple, right? Go back to your ABCs. Make sure that you're monitoring their cardiac, neuro, and respiratory systems closely. You want to frequently reassess these patients. Even in a short transport time, things can change rapidly, so make sure you're going back to the patient, checking back in. If it's a case of altered mental status, continually talking to them and trying to reassess and see where they're at. Think about how medications might be impacting your vital signs. So I already gave the example of beta blockers affecting your heart rate. And you may need to assess multiple pulse points. So again, remember that pulses may be diminished as a part of a normal part of aging. And so it's a good idea to have at least a sense of perfusion in different places, centrally, peripherally. All right. So we just finished talking about assessing an elderly patient and some of the things to consider, from communication to getting a history to doing your physical exam. And again, I want to recognize that these things are difficult, right? We started out talking about the fact that it takes time and patience to interact with an elderly patient. And now I've just told you that their physical exam might be misleading, their chief complaint might be misleading, and it can be really challenging. So hopefully some of the things that we talked about are good reminders for you about things to kind of focus on and where to focus your attention. And now we're going to jump into talking about the physiology of the aging body and the associated medical problems. So the summary, the highlight, is that every single organ system is affected by aging. And so we are going to go through pretty much one by one and kind of pick apart that organ system, talk about some of the changes and then some of the conditions that affect it. A lot of this is kind of background. We'll touch on a few kind of specific management things, but really this is about assessing and understanding the elderly patient. Okay, so some general changes. Total body water decreases, total body fat decreases. Many of the body tissues are undergoing fibrosis or scarring, and a lot of this contributes to progressive loss of the hemostatic system's ability to adjust, right? So you don't have as much body in your intravascular system, you can't control your temperature as well, and your tissues can't vasodilate, vasoconstrict, or your muscles can't, tighten up as well as they used to, and so a lot of this impacts the hemodynamic system. Talking about the skeletal system, there is, again, generalized tissue fibrosis, like we just mentioned, and there's changes in weight. So males' weight increases until they're in their 50s and then starts to decrease. Females' weight increases until their 60s and then tends to decrease. There is osteoporosis. So this is loss of the mineral from bone. This leads to maybe a change in posture. So I already mentioned, the importance of evaluating someone in a position of comfort and how their posture or skeletal changes may make it difficult for them to sit or lay down. There's a loss of height, an increase in thoracic kyphosis, so that's that hunching of the top part of the back, and they're much more susceptible to fractures. So this obviously plays into your traumatic evaluation or your evaluation of elderly patients who are victims of trauma. But all of these changes come as a result of kind of losing mineral from the bones. In terms of the muscular system, there's loss of kind of muscle bulk relative to the rest of the body. There's loss of cartilage, so this means that the body can't adapt to repetitive stress the way it could before. I'm sure we all know family members who have had knees or hips replaced, right? They just cannot recover from even those normal, typical stresses. And then there's increased bone resorption, so this contributes and feeds back into the skeletal system as well, and can contribute to that increased risk of fractures. In terms of the genitourinary system, there can be issues on both ends of the spectrum. So elderly patients may have issues with elimination, but they also may have issues with incontinence. When it comes to problems with elimination, the issue is that this may, although it may be a sign of kind of typical progression of aging, it may also indicate severe underlying illness. Having to strain when you go to the bathroom can actually contribute to syncope and TIAs, and the patients might be on drugs that are exacerbating this or making it worse. So a patient's main complaint may be constipation or issues going to the bathroom, but what else could be at play here? And this is where your history and your medication list is critically important. Issues with incontinence. So incontinence is an incredibly common issue for elderly individuals. So urinary incontinence occurs in 15% of elderly individuals who are living at home, and up to 50% of those living in a nursing home. Fecal incontinence occurs in about 16% of elderly individuals living at home, and up to 60% of those living in a nursing home. So this can be a normal part of aging, but it can contribute adversely to other medical issues, right? So it may lead to rashes or skin infections or ulcers, issues surrounding getting frequent UTIs, becoming septic, and it may also contribute to falls or fractures if someone is kind of trying to hurry to get to the bathroom or worried that they may be incontinent, those sorts of things. So although it's a common part of aging, it has implications for many of these disease processes. Many of the issues here are caused by anatomic changes, and some of the underlying diseases may contribute, and again, medications are a huge issue. In terms of the changes that occur in the renal system as we age, there is a 30 to 40% reduction in the number of functioning nephrons. So the functional units of our kidney that do the job of filtering and secreting are diminished. And there's a 50% decrease in renal blood flow. So the supply and the nutrition for the kidney is diminished. And this is exacerbated by medications. It can be exacerbated by atherosclerosis. So all of our patients who have heart disease, high cholesterol, may be worse off. And there may be anatomic changes like renal artery stenosis. This decline in renal function contributes to increased waste products building up. So patients may be uremic. They may have electrolyte abnormalities. Particularly important would be things like potassium and phosphate, which can contribute really adversely to other organ systems. They may have impaired clearance of their medications, leading to more significant medication side effects, or they may not be able to filter out as much water as they should, and that leads to fluid overload. So there's multiple different things that may result from kind of even just the normal process of aging and the changes that happen in the kidney. Obviously, for patients who have more progressive kidney disease or an underlying medical problem like diabetes that's exacerbating this, they're going to be at risk for all of these issues even more. What are the changes that happen in the skin and kind of like outer layer of our body? So the skin thins. There's less blood supply going to the skin. There's less collagen, so the skin is much more susceptible to tearing, and it takes a lot longer for it to heal. We've all seen an elderly patient who has just, scraped their leg on something. Seems like really minor trauma, and they have this huge skin flap, right? They tear easily, and then getting that to heal can be really problematic. And as a result of all of these things, patients are at increased risk for secondary infections. So I don't expect everyone to be doing a full comprehensive skin exam in the field, but if a caregiver says, oh yeah, we've been dealing with this wound or we've been dealing with this ulcer, we got to give that a look, right? We got to see what's going on there, because that might be the source of sepsis leading to their altered mental status, right? Their chief complaint was not, I have a skin problem. Their chief complaint was altered mental status, and we've got to dig down into that, and issues with their kind of normal body changes or normal healing might be at play there. Decubitus ulcers, we're going to touch on that specifically. So these happen in up to 25% of nursing home patients, mostly in individuals over the age of 70. So really are patients that are going to be less mobile, and often those cared for in nursing homes simply because the time and attention paid to moving and shifting and changing and caring for wounds may be less. Usually in bedridden patients, the location of these are going to be below the waist and on bony prominences, so hip bones, sacrum, those sorts of things. And the risks for decubitus ulcers are pretty kind of standard and apparent. So pressure, altered sensation, so people not being able to respond appropriately when they feel, or because they're not feeling, pain in that area appropriately, decreased activity, decreased mobility, poor nutrition, and then friction or shearing forces, so moving, shifting, without being able to appropriately lift or move a body part, all contribute to the risk of decubitus ulcers. Next, we're going to talk about the thermoregulatory system. So this really comes down to the fact that elderly individuals cannot control their temperature as well as younger individuals, and that is a normal process of aging. But with that comes complications. So the way that happens really is that the sweat glands as we get older do not produce, decrease in number, and they're not producing as much sweat. And so you need to be hotter to sweat, and you can't sweat as effectively in a warm environment. And that is one of our major kind of evolutionary mechanisms for how we cool ourselves down, how we get heat to evaporate off of us. And so that contributes to patients' ability to respond to changes in the environment. They have decreased shivering, so again, affecting our ability to respond appropriately to a cold environment in that case. Drugs can affect the ability to kind of control your body temperature, and again, we've talked ad nauseum at this point. We'll continue to talk more about medication influences. And then there might be environmental issues with patients living alone, right? Maybe they can't get to the thermostat to change the temperature. Maybe they don't have the finances to pay to fix the air conditioner. Maybe they've had a recent fall and can't maneuver around the apartment well, that sort of things. All right, respiratory system. Some of the kind of common changes as we get older. There is a decreased chest compliance and elasticity, and decreased muscle strength, so playing into, again, the skeletal and muscular system as well. Overall, we have decreased pulmonary function, decreased vital capacity over time. Our breathing capacity decreases by 60%. Our ability to maximally take up oxygen from the environment decreases, so we can't use the oxygen that we are getting as well. And then lots of other individual issues can affect underlying breathing issues. So kyphosis can kind of restrict the lung volumes, pollutants, tobacco use, all of these things will impact our pulmonary function. Some of the common causes of respiratory distress, COPD or emphysema, chronic bronchitis, asthma, pulmonary embolism, pneumonia. Now we're going to move into things that are not necessarily lung, right, but acute MI or congestive heart failure are going to impact our respiratory system as well. So another reminder to kind of think outside of just what is the chief complaint, and then pulmonary edema from a variety of different causes. COPD, the most common risk factors are cigarette smoking or pollutant exposure, but there is also a genetic predisposition. And the pathophysiology here is that we get airway inflammation, sputum production, and destruction of the alveoli. So air cannot get out as well. Patients can't ventilate or clear carbon dioxide as well, and they have kind of swelling and narrowing of their airways. They present with cough, dyspnea, and sputum production. They may use kind of pursed lips when they're breathing, and may have wheezing on exam. And the vital sign abnormalities that you may see in a patient with COPD are hypoxia, hypercarbia, changes in their acid-base status, and respiratory decline, so acute on chronic respiratory failure. And they're treated with oxygen, beta agonists, so albuterol, and steroids. Pulmonary embolism is kind of one of those things to think about if you can't find anything else very obviously causing a patient's respiratory symptoms. The classic symptoms are sudden dyspnea, tachycardia, and tachypnea, or sudden cardiac arrest. And the risk factors are decreased mobility and cancer or any kind of other hypercoagulable state. Again, elderly patients may not look the same as younger patients with a pulmonary embolism. They may not be as tachycardic. They may have a baseline oxygen need, and it may be difficult to tease apart, what is their oxygen requirement compared to their baseline. And then sudden cardiac arrest. I mean, we see sudden cardiac arrest from a whole host of different causes, but PE is something to keep in the back of your mind and to think about if you have a patient in respiratory distress without a clear cause. All right, we'll dive into the cardiovascular system, which I'm sure everyone is very kind of familiar with managing, but hopefully this slide gives you a little bit of insight into kind of why assessing and dealing with the cardiovascular system in an elderly patient may be a little bit more challenging. So patients who are elderly have a decreased response to catecholamines, so the normal stresses that kind of rev up our cardiovascular system are not going to have the same impact in an elderly patient. Their myocardium might be hypertrophied and less compliant, so it can't squeeze and work as well as it's supposed to. They're going to be more susceptible to mild ischemia, so the same ischemic insult that a younger person might be able to cope with or manage with or compensate with for some period of time is going to have a higher or bigger impact on an elderly patient. The conduction system deteriorates with time, and so this increases their risk of arrhythmias or dysrhythmias. Stroke volume declines, so they are physically not pumping as much blood out with each heartbeat. The speed and force of the muscle contraction decreases, and again, like we mentioned earlier, there's fibrosis kind of throughout the body, but particularly in blood vessels, and this makes them less able to compensate by vasoconstricting or vasodilating, depending on what would be warranted based on the physiologic change that's happening. We'll go into a couple of specific diagnoses, starting with CHF. So CHF is the most common diagnosis in hospitalized patients over the age of 65. Some of the common signs and symptoms might be urinating at night, large blisters on the legs, along with more edema and swelling of the legs, and bedridden patients, it's important to recognize, may have edema in places other than their legs, right? You get dependent edema, and so if you're up and ambulatory, that's going to go to your legs, but if you're bedridden, it may go to the areas where you're laying, right? So this may accumulate in the sacral area rather than in the feet or the legs. In terms of dysrhythmias, the elderly can't tolerate extremes of heart rates as well as younger patients, and this can lead to CHF or TIAs. If a patient has had no arrhythmia for their entire life and you're seeing them now, they're 67 and they have a new onset AFib, that should make you concerned for the potential for an underlying MI, right? Why did this patient's conducting system all of a sudden decide to flip into a dysrhythmia? And so important to get EKGs on these patients, obviously, but also have a high clinical suspicion for MI. And then many of the meds that our patients might be on may actually contribute to developing arrhythmias. Things like digitalis, beta blockers, calcium channel blockers, and even antiarrhythmics can have proarrhythmic effects in the elderly. It is not your job to tease all of this apart, but it is your job to get a history and have some sort of like inclination to like what medications is this patient on? Could they be dangerous? Could they be contributing? Or could they be affecting my evaluation of them? Types of aortic disease that the elderly are predisposed to, both thoracic aorta and abdominal aorta. So a thoracic aortic dissection would be the most common, typically coming with tearing chest pain, sometimes with some neurologic signs or symptoms, especially if that dissection impacts the arteries that go off to the spine at certain levels. And they may have asymmetry of their pulses or blood pressures. So again, it's important to assess pulses in more than one place in an elderly patient. Abdominal aorta is prone to aneurysm. So this typically presents as tearing abdominal pain, a pulsatile mass, but may present as unexplained back pain or lower extremity weakness, numbness, changes in the color of the lower extremities or diminished lower pulses. Hypertension is another common medical condition that affects the cardiovascular system in elderly patients. It's present in over half of people over the age of 65. Might be totally asymptomatic or might have nonspecific symptoms like headache or vision changes. And antihypertensives are, as we've already talked about, kind of a risky medication. Obviously important, but they may mask other disease processes or have implications when a patient gets acutely ill. Let's talk about MI for a second. Silent MIs are a lot more common in elderly patients. So as with all of the other organ systems, elderly patients may present atypically with what is a common diagnosis for you guys to see. So they might present with worsening dyspnea in the context of underlying CHF. They might actually present with more of sort of like signs or concerns for an acute abdomen, even tenderness or rigidity in the abdomen. They may have weakness, fatigue, syncope, incontinence, TIAs or stroke or confusion. So all of these things may be signs of an MI, and you are very likely to see elderly patients who do not have the classic, chest pressure, pain in the arm or jaw, all of those sorts of things that we're used to thinking about when it comes to MI. And this is a great example of when kind of a patient's chief complaint, right? Maybe their chief complaint is that they have been incontinent, right? Well, incontinence is a normal part of aging, right? We said that up to 50% of nursing home patients are incontinent of urine. But this patient has never been incontinent before. And now their new chief complaint is that they're experiencing incontinence. So your job is to understand and elicit from the history that this is a new issue and pay attention to the fact that this chief complaint that involves the genitourinary system may have nothing to do with that system, and there may be many other issues or processes that could be contributing. So is it something about their medications? Is it something about their cardiovascular system, like a silent MI? Is it that they actually had a seizure and were incontinent, right? Lots of things may be going on there, and that's why being really careful and thoughtful in terms of the history taking with an elderly patient can be so important. All right, so we'll leave the respiratory system and the cardiovascular system and talk about the nervous system a little bit. So some typical changes with the elderly. We all experience some degree of brain atrophy. The brain volume decreases in size and weight. This changes our susceptibility to getting things like subdural hematomas because there's stretching of the veins that typically bridge between the brain and the skull because the brain has kind of shrunk down. So we're more prone to subdural hematomas. There may be a significant number of brain cells lost in certain areas over others, decreased blood flow, and the key at the bottom there, that altered mental status is not necessarily a sign of a problem with the with the nervous system, that it may be a sign of something completely different. Talk about some of the common issues when it comes to neurovascular systems, starting with delirium. So if you remember way back to the beginning of this discussion, we talked, or I mentioned briefly, right? Don't just assume that all of your elderly patients are demented or senile, right? There are acute changes that may happen that we need to tease apart. One of those may be delirium. So delirium is an acute confusional state, and it's typically triggered by an underlying problem. So yet again, the chief complaint of new onset confusion or new hallucinations may be a sign of something completely unrelated, and we need to pay attention to the fact that this patient is typically highly functioning or neurologically intact or does not have Alzheimer's or any other form of dementia, and that this change was new and acute. Delirium involves a rapid decline in cognitive function, disturbed intellectual function, disorientation, decreased attention span, poor recent memory, and poor immediate recall. It might also look like poor judgment, restlessness, altered level of consciousness, being highly suspicious, having delusions or hallucinations, or a change in that person's kind of general disposition, just how they typically act around other people might be different. Here's a list of some of the common causes of delirium. It's sort of an obnoxious slide for a reason, right? I just said that delirium is usually a sign of something else going on, right? But it might be any of these things and more. So Are they hypoglycemic? Do they have an infection like pneumonia or even a CNS infection or maybe even sepsis or shock? Could they be dehydrated? Could there have been some occult trauma? Is this an issue with their medication? Again, whether medication toxicity or interactions. I put dehydration on there twice because it's so important. Could this be a stroke, a tumor, some other kind of head injury, any kind of intoxication, alcohol or drug use? Lots and lots of things. Hypoxia there at the end. A lot of different things that might be at the root cause of a patient developing delirium. And a lot of this is going to be a little difficult to tease apart, but there are things that you can do, like checking a sugar, checking an EKG, doing a stroke scale, that are important to at least your initial assessment of these patients and trying to tease apart some of what is going on. Really important to assess their vital signs, reassess them, reassess their neurologic status. And if you find something that is easily treatable in the ambulance, like hypoglycemia, right, then you can do something about it. Oftentimes, this is going to be a big workup and it's going to involve plenty of labs and maybe imaging at a hospital, but you need to get things started and you have to have a broad view of what might be contributing when you see a patient with delirium. So how does this how do we distinguish delirium from dementia? I've already kind of touched on it, but delirium is an acute change and dementia is a more chronic change. Delirium is sudden. There's usually something underlying it. The signs and symptoms might change or fluctuate. Usually happens over the course of hours to weeks. And if we can find the underlying cause, this is so key. If we can find what is causing this, then you can reverse delirium, right? And what an incredible thing to be able to do for a patient if we can find and fix the thing that is giving them this acute change in their mental status. Dementia, on the other hand, is more gradual and actually involves structural changes in the brain. It's not reversible. All right. So we're still in the neurologic system, and I put syncope here, but again, it's one of those things where, although it is maybe typically viewed as a neurologic symptom, has plenty of other possible causes. So syncope is just altered mental status caused by a transient interruption and decrease in cerebral blood flow. So less blood flow to your brain. Your body says, you know what? It's too difficult to fight against gravity. I'm going to make myself flat. And you syncopize so that you can easily get more blood flow to your brain. But this may be, as I have on the right here, due to a neurologic condition like a stroke or a transient ischemic attack. Might be due to a seizure or diabetic neuropathy, but commonly is going to be due to other things, particularly related to the cardiovascular system. So heart attack, arrhythmias, maybe a result of some of the medications that they're on, again, or maybe they're hypovolemic as a result of an occult bleed or some underlying issues with their thirst mechanism. The next neurologic condition to talk about is stroke. So these are some pretty harrowing statistics and just there to remind us of the importance of thinking about treating and managing this condition. So every 40 seconds, someone in the United States has a stroke. Every 3 minutes and 14 seconds, someone dies of a stroke. And stroke is one of the leading causes of serious long-term disability for elderly individuals in the U.S. Stroke reduces the mobility of more than half of stroke survivors over the age of 65. So similarly to the cardiovascular system, where less ischemia or smaller insults are tolerated less well in elderly patients, the same sort of applies to the brain, right? A younger person who has more neuroplasticity, better blood flow, greater brain volume, all that sort of stuff, may be able to compensate and regain function from a similar stroke compared to an elderly patient, where a lot of these strokes are causing significant challenges to their daily living. And it's expensive, so stroke costs in the United States are pretty impressive. This is just an updated chart to show you kind of the most common causes of death. This was updated in 2022. Stroke used to be at number 3. So heart disease at number 1, cancer number 2, Stroke used to be here at number 3, but now it's bumped down to the 5th most common cause of death in the United States, now behind unintentional injury, which is a whole separate can of worms and a whole separate discussion, and COVID-19, which made it to the list. This is a map showing you stroke death rates by county. So darker shaded regions have higher rates of death from stroke. A lot of this map actually looks sort of similar to the map of where the most elderly patients are in the US, but also maps to kind of access to resources in rural areas as well. These two graphs show first the kind of disability that individuals experience as a result of stroke. And so stroke is this kind of like dark blue section. So you can see, like we mentioned, elderly individuals have significant mobility issues and disability resulting from stroke. And so this just kind of shows you that in graphical form. And then at the bottom here is the forecast or the prediction of how many strokes we're going to be dealing with and what patients are going to be dealing with strokes in the 2050. This again maps to the predictions of what our population in general is going to be looking of stroke. Some kind of key points in terms of your evaluation of stroke patients, remembering that there are ischemic and hemorrhagic strokes. Ischemic strokes are by far the most common, accounting for almost 90% of cases. These are usually either thrombotic or embolic. And the treatments for ischemic stroke are like IV TPA or endovascular procedures, or addressing maybe the underlying root cause of where the embolic disease is coming from, maybe from the carotid, for example, as opposed to obviously very different management for hemorrhagic strokes. Signs and symptoms of stroke, I think you all know this, so we'll go through it sort of quickly. But altered mental status, obviously, is a key one. Any kind of facial droop, headache, aphasia or dysphagia, hemiparesis, so one side of the body not working correctly, hemiplegia, paresthesia, so sensory changes, changes in their gait, incontinence. Again, here we are back again talking about incontinence and the fact that it has nothing to do with the genitourinary system in some patients. Confusion, agitation, dizziness, vision problems, or it might be the reason for a fall. So again, a fall may not be mechanical. It may be the result of some sort of underlying medical issue. Moving on from stroke, we'll talk about seizures for a second. Any kind of first-time seizure in an elderly patient is a danger sign, and we're going to have to work it up pretty significantly. Lots of different causes: strokes, syncope resulting from just transient blood flow changes, arrhythmias, any kind of alcohol or drug-related issues, a tumor or mass, head trauma or hypoglycemia are all reasons for seizures in elderly patients. Parkinson's disease is just here to, as sort of like a reminder, as a common chronic disease that you may encounter. So it's the 4th most common degenerative disease in the elderly. It affects a certain part of the brain called the basal ganglia, which affects our ability to kind of coordinate movement well. There's different types, but the common signs and symptoms are a specific kind of pill rolling, tremor, muscle rigidity, a very shuffling, slow gait. They might have what we call a mask-like facial expression, so just this blank facial expression where you're not getting much from the person. A slow or monotone voice, and can also cause anxiety and depression. And that's that with the neurologic system. So we talked about seizures, strokes, delirium, dementia, Parkinson's disease, so lots and lots of stuff going on in the neurologic system when it comes to elderly patients. Now we're going to move on to talking about the gastrointestinal system. So some of the changes that happen as we age, we can have decreased saliva production, decreased GI mobility, and actually fewer taste buds. So the fact that things don't taste well, the fact that it's harder to eat certain foods actually may contribute to malnutrition or even aspiration. Patients might have decreased liver function. This affects detoxification and clotting most prominently. And then there's a higher incidence of GI bleeds for a variety of different reasons in the elderly patient population. Some of the most common GI conditions, the most common GI condition is GI hemorrhage, and this results from a lot of different causes. So we're used to kind of distinguishing upper from lower GI bleed, which is a good kind of initial distinction, and then thinking through what some of the underlying causes might be. Might be peptic ulcer disease or gastritis, might be esophageal varices, particularly in patients who have had alcohol use issues in the past. Might be due to NSAID use or abuse, diverticulosis, tumors, ischemic colitis, or arteriovenous malformations are all different reasons for elderly patients to develop GI bleeds. May present with coffee ground emesis or dark or bloody stool, depending on the source of the bleed. They may present with orthostatic hypotension or syncope, right? An occult GI bleed leading to kind of slowly evolving hypovolemia or anemia may lead to orthostatic hypotension or syncope. Might actually present as confusion. So yet again, another neurologic sign or symptom that is actually kind of masking or making it difficult to figure out the underlying cause, which is actually in the gastrointestinal system. May cause an increase in anginal symptoms or heart attack symptoms, weakness, or dyspnea. Some other common abdominal emergencies to be aware of, especially for patients over the age of 75. Strangulated hernias and intestinal obstructions are fairly common. Gallbladder issues. Acute appendicitis actually has a pretty high fatality rate for elderly patients. Again, probably because it's not right at the top of our list of likely diagnoses, and patients are going to present atypically without maybe the typical focal right lower quadrant tenderness that we would expect of younger patients. GI bleeds, like we've talked about, and then ruptured abdominal aneurysm as well. When things are, we already mentioned a couple of GI issues like GI bleed that may present as symptoms of another body system, but there are also other body systems that may present looking like gastrointestinal pain or like an acute abdomen, things like MI, pneumonia, any kind of genitourinary or retroperitoneal disease, or any kind of kidney disease, or metabolic diseases may all present primarily with GI symptoms. So again, difficult to tease apart, but your job is to have a broad sense of the different sorts of things that could be going on, the types of things that you should evaluate for, and that you can evaluate for in the pre-hospital setting to try and tease some of this apart, right? Think about MI and get an EKG in an elderly patient with isolated abdominal pain, right? It may not be that their underlying illness is truly related to the gastrointestinal system. The endocrine system, so your hormones, there's a higher incidence of diabetes, thyroid dysfunction, hormone dysfunction. These are really difficult to tease apart in the field, but I just wanted to make sure that we mentioned them. The one thing that you can do and should do is get a fingerstick glucose and treat it when appropriate. The immune system. So as we age, we are not as good at fighting off infections. So there's a diminished immune response. There's decreased function of our different infection-fighting cells. We're more susceptible to illness. Those illnesses last longer and can be more severe. And there are some important vaccinations for the elderly to help prevent some of the most common illnesses and new stuff that's kind of come up recently, like the RSV vaccine and now the yearly COVID vaccine. But these things may help our elderly patients avoid some of those common and life-threatening illnesses. Common illness for the elderly is the flu. We're right in the peak of flu season now as we're recording this. It's now January, but peak months are your winter and early spring. We all know kind of how the flu spreads and common symptoms, but it is vaccine preventable in many cases. And there are actually medications for it that are not perfect, but can be used for patients who have a diagnosis of the flu. And the signs and symptoms down here are things that I'm sure you all know, so we won't go into too much detail. Pneumonia is a bacterial infection of the lung rather than a viral infection. This is the fourth leading cause of death in patients over the age of 65. and it's much, much more common in nursing home patients between living in a communal setting and being exposed to other individuals who are sick, to having decreased mobility, not getting up, moving, taking big breaths, clearing your lungs. All of these things contribute to an elderly individual's susceptibility to developing pneumonia. And there is a high not only mortality rate, but also complication rate associated with elderly patients who develop pneumonia. Typically presents with a high fever or chills, shortness of breath, cough, pain, chest pain, increased respiratory rate, but be aware again that they may present atypically. So an elderly individual may actually not have such a prominent cough, and they may not develop a fever, like we mentioned when we talked about the kind of thermoregulatory system. They may have belly pain rather than chest pain, like we just talked about. Pneumonia, especially if it's kind of moving into more severe infection, can present with altered mental status or confusion. So all of these things are signs and symptoms to be aware, again, that they may not relate to the main system that the person is concerned about, but might be a sign of an underlying illness. So if you detect, hypoxia and increased respiratory rate on your exam, you need to be thinking about this and treating those issues, even while the patient is concerned about, maybe belly pain. Sepsis is an acute disseminated infection, bloodstream infection, usually leads to fever, chills, high heart rate, high breathing rate, altered mental status. Septic shock, obviously, is when that has progressed to a shock state with hypotension and affecting your end organs, including your mental status. But elderly individuals with their kind of diminished ability to fight off infections are at higher risk for developing sepsis. It usually comes on quickly. Often some of the early signs include altered mental status. Remember that they may not have a fever. They may actually be hypothermic as well, so a cold temperature is not reassuring in these patients. Specific rashes might point us in the direction of a particular cause, and they may have other symptoms, particularly related to the gastrointestinal system, that might make it hard to kind of tease apart that this is truly sepsis. All right, the hematologic system, I think we're coming to the end now of the different organ systems that we're going to talk about. So just to comment on kind of the changes that we see over time. So decreased circulating blood volume, similar to that way back at the beginning of this section, we talked about lower water volume as well. So decreased circulating blood volume is an issue. Lower production of red blood cells leading to anemia. Nutritional deficiencies that might be due to a whole host of reasons, from financial insecurity to typical changes in someone's ability to taste or produce saliva, might actually lead to anemia. And then other chronic diseases can also lead to anemia. So that's all of the body systems that we are going to talk about. Again, as we age, there are going to be standard expected changes over the lifespan for kind of how the body is going to change and decline with time. Our job when we have a patient in front of us is to keep an open mind about what organ systems may be involved in producing the symptoms that a patient is complaining about. Do a comprehensive assessment, get a good history, get a good medication history, and don't anchor on belly pain being to do with the belly, or altered mental status being to do with the brain, right? We got to think about the fact that other organ systems are going to be at play there. All right, so that kind of closes out our discussion about medical issues. In the geriatric patient population, we're going to talk really quite briefly about geriatric trauma and then about elder abuse. So some statistics about geriatric trauma. The elderly account for 10 to 15% or so of all victims. They, despite being in the tens percent of victims, use a lot of the healthcare expenditure related to trauma. Any traumatic patient over the age of 80 is 4 times more likely to die of their injuries, and the most common causes are falls, car accidents, auto versus pedestrian, and then assault. This gives you, again, just another way of looking at some of these statistics. So we saw the bar graph of the most common causes of death, kind of regardless of age. This is the most common causes of death in elderly individuals. So although unintentional injuries was like here at number 3 in that other graph, for elderly individuals, it is lower, but it's still top 10. And then within that, the most common causes are falls and MVCs. Fall rates are on the rise. Again, more elderly patients. Those patients are older. They're going to be more likely to fall as a result of all of the normal changes that come along with aging. And so falls have increased exponentially over the last decade or so. The number of older adult drivers is also increasing. So there's been a significant increase in the number of elderly adults who are driving. They are thus at risk, and as with anyone on the roads, of getting into car accidents. Some of the general concepts around evaluating geriatric trauma patients. Serious injuries may result from seemingly minor trauma, right? So a small fall can be deleterious. Maybe it resulted in a hip fracture or subdural hematoma, but major injuries can come from what seem like small trauma. They are not only at increased risk in the acute phase of their trauma, but also in recovery from that event. So this is not sort of a one and done for our elderly patients. It has implications moving forward into their recovery. There are changes to the cardiovascular system, like we've discussed, that make it difficult to understand the presentation and then also manage elderly trauma patients. So they cannot compensate for hypovolemia as well because of the fibrosis in their blood vessels, and so they can progress to decompensated shock really rather quickly compared to others. They don't tolerate They don't tolerate hypoperfusion very well. And we mentioned that when it came to stroke and MI, right? But that has implications for a whole host of other body systems when you have a low perfusion state due to hypovolemia or hemorrhagic shock in a trauma situation. Their medications may mask the signs of shock. So again, we'll use beta blockers as an example. A patient who should be tachycardic and hypotensive may look like they have a normal blood pressure as a result of their beta blockers. And their poor cardiac function may lead to issues when we're trying to fluid resuscitate. This is not something that I would be concerned about in the field, but is something to think about later on. But a patient with severe CHF is not going to be able to be fluid resuscitated as aggressively, potentially because of their underlying heart disease. And remember again that there may be a medical cause around any kind of traumatic injury, right? The person who gets in a car crash on the interstate may have had an MI and gone unconscious, may have had a seizure and gone unconscious. It was actually a medical event that caused the trauma. So thinking about that and evaluating for those things, getting an EKG, getting a blood glucose, if you can and if the patient's stable enough, may be helpful in situations like this. And then their medications are problematic. We've talked about this so many times during this talk, but medication side effects or interactions might be the reason for a fall or another traumatic event. These patients, like we mentioned, are going to decompensate. They're at higher risk for respiratory failure. They are at higher risk for fractures as a result of all the skeletal changes that we talked about, and they're at higher risk for spinal cord injuries. So let's go through a couple of different systems. So starting with head injury. Head injury is common, again, even with what might be perceived as minor trauma in any other patient. It is the most common cause of mortality. There is cerebral contusion in a third of elderly individuals who have a head injury, which I think is really rather remarkable. And mortality is really quite high. And realize that the patient might have some amnesia to the event. They may have lost consciousness and may have actually forgotten the details of the injury. Cervical spine injuries are an important thing to think about and pay attention to for elderly patients. These result from those typical changes in the skeletal system that happen with age, like osteoporosis and arthritis, putting patients at risk for more significant bony injury. And any kind of sudden movement can cause actually injury to the spinal cord even outside of having a fracture. And they may not have as good sensation to be able to complain about the pain from a fracture. So thinking about spinal immobilization and being really cautious with these patients and understanding that even a reassuring exam should not necessarily get this patient out of a collar in the field. Chest trauma The chest wall, like we talked about, is not as compliant in elderly individuals. Our respiratory capacity and our reserve is not as good as we age, and we can't tolerate low oxygen states as well. So there are more significant complications from chest trauma in elderly patients, like acute respiratory distress syndrome, pneumonia, atelectasis. And so these patients, often even with just a couple of rib fractures, an elderly patient might find themselves in the surgical ICU, for example, because their lungs cannot compensate for or recover from an injury like that, as well as a younger individual. Skeletal changes mean that you might get significant fractures to the torso that you might not see in a younger person. And our patients with COPD, if we have to bag them or support them, are at higher risk for pneumothorax. Abdominal trauma, there's a high rate of significant intra-abdominal injury, up to 30% of patients with abdominal trauma. This includes both solid and hollow organ injuries, and there's high mortality, reaching up to 30% for patients who sustain intra-abdominal injuries. Burns, the elderly population with all of the kind of changes to the blood supply in the skin that we had talked about are at particular risk for mortality from burns, similarly to very young patients. And this is for a whole host of different reasons: the skin changes, underlying diseases, poor immune response, and all that. They're also at increased risk of shock. So the volume loss as a result of a burn can put an elderly patient into shock pretty easily. And we need to make sure that we're fluid resuscitating these patients. All right, so like I said, a pretty quick overview of trauma. Hopefully some of the general concepts that we talked about around the changes that occur in the organ systems of elderly patients kind of helps you to think through not only the medical side of things, but also the trauma side of things a little bit easier. And we're going to end, unfortunately, with the topic of elder abuse. So there's different types of elder abuse: physical abuse, sexual abuse, emotional or psychological abuse, neglect, or financial abuse or neglect. Abuse, including neglect or exploitation, is experienced by about 1 in 10 people over the age of 60 who live at home. So 10%, which is really a phenomenal and concerning number. There were, between 2002 and 2016, more than 643,000 older adults who were treated in the ER for non-fatal assaults, and over 19,000 homicides occurred in this age group. So these patients are not immune to non-accidental injuries and trauma. Some of the indicators that you may see on your exam or your assessment of an elderly patient that might indicate abuse would be scratches, cuts, burns, or traumatic alopecia, which is where hair has been torn off. Restraint injuries, right? So patterned injuries or bruises around the wrists or the legs. Decubitus ulcers, although they're common in elderly patients who are sedentary or non-mobile, particularly our nursing home patients, a poorly cared for wound may be a sign of neglect. Uses of chemical restraints, so patients who are have sort of like strange things on their medication list, or who are being administered certain meds, just to calm them down, quote unquote. Repeated, unexplained, or hidden injuries. Any kind of time lag to getting treatment. So again, this isn't, an absolute, right? Like someone may delay when they seek care for any number of different reasons, but a patient not getting care for a particular complaint may be a sign of abuse or neglect. And then doctor shopping on the part of caregivers to kind of avoid someone catching on to some of these patterns may be a sign of abuse or neglect. The perpetrators of abuse often are relatives, maybe an involuntary caregiver, so someone who didn't want that role and is now placed in the role of caregiving for an elderly individual. Often they live with the victim, and it's difficult, it's stressful, it can take a toll on a caregiver to care for an elderly individual, and as a result, they may have poor impulse control and may snap and kind of be perpetrators of of elder abuse, and that individual may or may not have drug or alcohol abuse themselves. What's your role as an EMS clinician? If you can at all interview patients alone, obviously the patient needs to be able to communicate effectively with you, and you need to be in a situation where you can do that. But if you have concerns for elder abuse, it really is important to get that patient on their own to get your history. Document your facts and findings, right? If you're seeing patterned bruises or bruises in strange locations, you need to document that. And remember that you're a mandated reporter, right? As medical professionals, we are mandated reporters, and what it takes to make a report of abuse or neglect, you don't need to confirm it. You don't need to know who did it. You don't even need to know what happened. All you need is a concern. So if you have a concern or suspicion for abuse or neglect, you are a mandated reporter. You can report to a variety of different places. In Ohio, it's 421 Life. You may report to your hospital system, and they may have additional resources and stuff. And then there are some other resources there. But please remember that it is sort of incumbent on all of us, again, whether or not you know what happened or can confirm what happened, that doesn't matter. What matters is whether or not you have a suspicion or concern for abuse or neglect. And with that, we'll end. And I appreciate everyone for staying and paying attention. I know it's a long presentation and a long discussion, but I really hope that we've given you a little bit more kind of details, information to really understand how to evaluate your elderly patients and why we see some of the things we do and why it's sometimes really difficult and challenging to kind of get to the bottom of things when it comes to evaluating, diagnosing, and treating elderly patients. Thank you so much.